So as Megan said, my name is Kendra Julius, and I am a Quality Enhancement Specialist for CQL. I've been working for CQL for just over 2 years now, and I previously worked for a provider organization. Uh, so today, throughout the webinar, we're going to kind of go over some of the same things that we've talked about in previous webinars, but then we'll dig a little deeper into what Factor 5 is all about, which is best possible health. If you guys have any questions, like Megan said, please type those into the chat box, and we'll address those at the end if time allows. So for anyone who needs a little refresher on what CQL's vision, mission, and values are, is our vision is a world of dignity, opportunity, and community for all people. I think it's really important to emphasize the all in our vision, because what we're saying is that all people are important, not just people with disabilities and not just people who share our same beliefs. When we look at building our communities, we need to keep in mind that lots of different people will be using those kinds of communities, and we don't want to exist in a silo specifically for any one type of person. Our mission is CQL is dedicated to the definition, measurement, and improvement of personal quality of life. Again, the emphasis is on the personal part of this. My definition of quality of life probably looks very different from yours, and that should be celebrated and supported. As we are supporting people to define quality, we are supporting them to live the best possible lives they can. This is a really great quote. I really like that Jeff Peterson shared this with us. Quality is a continuous journey. It's not a destination. We really believe that changing practices, learning, and growing are all signs of a healthy organization. We partner with a lot of providers and systems with this in mind, that quality is a continuous journey. We're never going to quite get there. It's not a destination. And providers that are committed to providing quality supports, as defined by the people they support, share the same idea that we're always going to be on that journey towards quality, and that the target will likely move because people's expectations change. And that's a good thing. At CQL, we use an appreciative approach to quality enhancement. We believe that all organizations have things that they're doing that are really great, and we'd like to support them to spread those great practices to other areas that might not be as strong. We don't say organizations have deficiencies. We get enough of that through audits and other types of surveys. Rather, we believe that organizations we partner with have the skills to be the best organization, and so we support them to learn what the opportunities may be to help them get there. And again, we really believe in continuous quality improvement. We always believe that we don't have everything mastered and that there are opportunities to learn new skills, whether in our personal lives or professional lives, or as an entire organization. And that's how we can provide supports in the best ways to meet people's needs and expectations. So today's agenda is we're going to go over what the basic assurances are. We'll move into a little bit of the process and evidence collection. If you've been on any previous webinars for this series, these two pieces will be very similar to what they've been in the last 4. We'll talk a little bit more about Factor 5. There are 6 indicators overall in Factor 5. So we'll go indicator by indicator and look at the different probes that make up each indicator a little in depth and how the concepts may be implemented at your organization. We will talk about what CQL reviewers will be looking for in each area. We'll talk about validation and decision making. How does CQL staff get to the decisions that we make to better support you guys? And we'll also talk about data points you might want to look at in Factor 10 related to best possible health. And then finally, at the end, we'll take questions as time allows. So if you have any questions, please feel free to type those into that chat box, like I said before, at any time throughout the webinar, and we'll get to them as we have time. So the basic assurances are the foundation for quality within an organization. There are 10 different basic assurances. The last 4 months, we've gone through factors 1 through 4 on this webinar series. We'll continue these webinars until next February to really support you guys to get a deeper understanding of what the basic assurances are and how they can be used. If you have any questions about any basic assurances, it's a great idea to look into your basic assurances manual. It goes over what the basis is for each factor, so kind of where it came from and why it's important, what we are looking for, and what evidence and questions CQL may be looking to gather, or questions that we may have when we're on site to be able to validate those different areas. The basic assurances focus on essential, fundamental, and non-negotiable requirements for all service and support providers. I really like that it says non-negotiable, because that pushes us to think about what are the most basic types of support we should be providing to all people, regardless of the types of services. And what's essential for a building block for that foundation for someone to be able to define their own quality of life. Today, we're going to talk a lot more about what the non-negotiables are in Factor 5. Organizations are encouraged to implement consensus best practices in relation to each measure. And the basic assurances require more than compliance with licensing and certification standards. We use this tool to understand the effectiveness of practice, the perspective of each person. One thing you might notice if you've gone through CQL accreditation is that we may have higher standards than what you're used to from the state or from other entities, and that's a good thing. We aren't just that foundational, this is what you have to do to be able to provide services. This is what would you do in a perfect kind of scenario to give people the best kind of lives that they would like. And I think that's why organizations choose CQL, is because we're always pushing organizations to be a little bit better and a little bit more person-centered. So the structure for each basic assurance factor is kind of like that overarching chapter. Within the chapter, there's maybe different sections of that chapter. So those are the indicators, right? So 5B is people access quality healthcare. That's one of the indicators of the 6 within best possible health. But then under that, there are different pieces that make up that as well. So those are called the probes. For 5B, there are 5 different probes. So we'll go a little more in depth into each of these probes in just a bit, but that's kind of how it's laid out. Okay. 2 components are evaluated when we do a basic assurances validation: the system and the practice. The system is organizational supports that provide the structure for those practices. So think of that as like your user manual. How do you know what to do and how to do it? So it might include policies, procedures, staff training, or other types of systems. The organizational practice is what is observed in daily operations. So this is how do you use the information that's in your user manual to actually provide those services. Sometimes we see that a practice may be in place, but the system is not. And that's something that may come up during accreditations, especially in factor 5 under indicator 5B. And that might be because the main person that's in charge of healthcare, or the nurses or medical staff, they've been with the organization for a while. They really know what people need in order to make sure they're getting all of those evaluations and screenings. But if that person or if those people were to leave the organization, or something were to happen to those people, there's not a clear practice, a clear system in place to make sure those practices continue. So if that were the case, where the practice was in place but the system was not, we would ask the organization to really make sure there's policies and procedures. So if that turnover happens, or if something changes, we can make sure that practice weathers the storm, so people are still getting those good quality supports. Throughout an accreditation, we gather lots of different types of evidence through our process. And our process includes reviewing documents, doing observations and visits, so going to people's homes or day programs or work sites or whatever the case may be, talking with people through focus groups. We often have focus groups with families, with people supported, and with DSPs, sometimes with all 3 groups, sometimes with just DSPs and people supported. It really depends. Factor reviews, so those are the meetings where we sit down and talk about each factor with the people that the organization's chosen to be a part of that factor discussion, and POM interviews. So as it pertains to best possible health, for document review, we'd look at policies and procedures that have to do with health. We'd look at committee meeting minutes, so any committees that have any say over healthcare things. So whether that may be the safety committees looking at medication errors, that would be something we'd want to see as some documents to back up the systems and practices. Completed nursing and self-medication administration assessments. Recent hospitalization data. So if people have been hospitalized, we'd want to see, is there an incident report that kind of documents what happened and how it was followed up on. Medication error data. So if there's been any medication errors, which there probably are you looking at the data on an individual and a system level? We'd want to see that as part of our documents. And we'd want to look at individual medication error reports as well. Staff training records. So, staff, are they trained in first aid and CPR and, recognizing signs of emergencies? People's records and person's support plans. So that's only with the person's permission, of course, but we want to see, if someone has healthcare supports, is that written into their plan? And if there's been things that have happened that have necessitated, any kinds of emergency room visits, is that followed up on? And are people getting those evaluations and screenings that they need? Whoops. So with observations and visits, there's a lot of different things that we'd be looking at here, but some of the things include observing medication administration. Again, we don't always do this, but sometimes it happens naturally when we're at people's homes. Meeting with people who've had recent healthcare changes. So if you're, supporting someone who has diabetes and recently started using insulin to manage their diabetes, we might want to chat with them about that and what supports they're getting. Conversations with people about self-administration. So if people are administering their own medications, we want to talk to them and see how that's going, see what support they get, that kind of thing. And medication storage. We're kind of snoopy when we go and visit people, and often people supported give us tours of their own homes, and if there's something locked, we'll ask, what's behind this, why is it locked? And a lot of times people will say, well, that's where they keep my medications, or that's where they keep so and so, we want to see that those medications are being stored safely. But if people are self-administering, we also look at that and what does that look like for each person. We also do focus groups, and like I said before, they may be conducted with people supported, staff, families, and others, depending on the types of services and the accreditation. Focus groups allow us to better understand systems and practices from the perspective of those that are affected by them. So some questions we might ask in relation to best possible health is, who chooses your doctors? And that's the question we'd ask of people supported. We might ask staff, how do you support people to manage their own health? And we might ask family members, does the organization ensure your family member has their health concerns addressed? And often the information that we get from focus groups is really, really influential and validating information because, it's direct from the people who are receiving the services or, providing the direct service. We also do factor reviews. So each factor is reviewed with organizational members that have a role in the implementation of systems and practices pertaining to that factor. So it's really important that when setting up those factor meetings, you're cognizant that people from all different service lines within the organization are available for those discussions. So of course, it's important to have nursing represented in Factor 5's review. It's also really great to ensure that someone from residential or day program or community living or whatever other services you might provide is also there to talk, because they'll tell you how it's being done day to day, with the people that are receiving the services. It's also an opportunity for the organization to provide examples of what each area looks like in practice. So you're welcome to bring people supported to share their success stories to illustrate the factor, or to share success stories that you've had, with staff or anything like that. Some organizations, have had people come talk about people who talk about their experience with maybe having cancer or having, needing to use insulin to manage their diabetes, or maybe being able to get off of all of their medications because they lost a bunch of weight, whatever the case may be. You're welcome to bring those success stories there if the person wants to be a part of that discussion. It's also an opportunity to ask questions and share best practices. So we really want these meetings to be collaborative. So if you have questions about any factors or probes or indicators during those meetings, we can talk about that. If you, just have a situation that you want to run by us, we're more than willing to chat with you guys during the factor review about that. With the personal outcome measures, that's the tool that we use to better understand quality of life through the perspective of the person. So the person's experience helps us understand the effectiveness of systems and practices implemented by the organization on that very, basic unit level for the organization. So interviewees are often selected from categories such as people with restrictions in place, people with extensive health supports, or people that have experienced abuse and neglect. And the reason we choose people from categories like that is because we're really trying to validate the basic assurances while also doing the POM interview. We also sometimes just do targeted conversations with people, maybe when time doesn't allow for more personal outcome measures to be done, but that's often done with people who have extensive support needs, either because they don't want to, sit through that long of an interview with us because they may have some serious health concerns going on, or because we're doing other POM interviews and we just really want to touch on healthcare and what that looks like for that person. So to the indicators. The first indicator within Factor 5 is Indicator A. People have supports to manage their own healthcare. And this one's really exactly what it sounds like. How are we supporting people to self-manage their healthcare? So do people get to choose their own healthcare providers? That is going to be as much choice as everyone else has in that geographic area. Where I live in rural South Dakota, I have a lot fewer choices than someone in New York City may have. But I might have more choices because I have access to, my own vehicle and I can drive wherever I would choose to. So again, it just has to be as much access as people in similar situations have, but also the same kind of choice that you and I have, where we weigh those pros and cons of maybe traveling farther or paying out of network costs or whatever the case may be. For probe two, do people make and keep their own healthcare appointments and records? So how are we supporting people to decide what they want from their appointments? When do they want them to be scheduled? Who do they want to see when they're scheduling appointments? And are we supporting people to schedule them themselves or with as much support as they may want? So if someone, needs to schedule their annual physical and they have a job or they go to day program or, they just have things going on in their lives, which we all do, right? Do we talk with the person and find out, when do you want your physical to be scheduled? What's a good time of day for you? What's a good day of the week to be seen? Is there any dates where you're just not available or you don't want to go? Do you prefer Fridays over Mondays or, whatever the case may be? And if the person wants to be on the phone with their provider to schedule that, do we support them to do that? Also, do people have access to their online medical records? I know that's something I do a lot in my life, is I creep on myself and look at everything my providers have written about me in the like electronic health system that my doctor uses. Do people have that same opportunity when we're supporting them to look in there and see what their providers are writing, to look at their labs that came back or whatever the case may be? If we use Therap or other electronic systems, are we supporting people to have their own access to that? And do people get copies of all of the information that's shared at their appointments? For probe 3, are people provided understandable information about their health, their medications, their treatments, including the purpose, intended outcomes, side effects, or other risks and alternatives? Are they then supported in making choices regarding their medical care? And are people provided understandable information about advanced directives, including psychiatric advanced directives, and support to develop one if desired? This probe is huge. It's got a lot of different things in it, but it's really the meat of what indicator A is. So do we make sure people understand their health? Do they understand why they're taking medications that they're taking or doing treatments that they're doing? Do they know what that purpose is of that and what we hope to get from that? Do they know what the side effects are so they can identify if something's not going right, or if they can decide if that treatment or medication is not right for them because they're not willing to accept that side effect? And are they provided other risks that may happen from doing those treatments or side effects or not doing them? And are they provided with alternatives? Only with that much information can people really make informed choices regarding their medical care. And as far as psychiatric advanced directives and other directives go, that's a mental health advanced directive is a written document that describes what a person wants to happen if at some time in the future they are deemed unable to decide for themselves or to communicate effectively. It can inform other people about what treatment they want or don't want from psychiatrists or other mental health professionals, and it can identify a person to whom they've given the authority to make decisions on their behalf. A mental health advanced directive is, just one of many different types of healthcare directives that can be made, but do people have the supports to determine who's going to make those decisions for them in the event that they can't make those decisions anymore? And have they been, given all of the information that they need to decide if they want to have one of those in place or not? Probe 4, do people understand their medical and medication histories? Again, it's really hard to make an informed choice about what preventative treatments you want if you don't understand, that you may have a higher risk for something, or that maybe you can't take a certain medication because you're on a different medication, or whatever the case may be. It's really important to know your own history to be able to make choices about your future. There's 5 more probes under indicator A. So are the person's preferences and ability to self-administer medications and treatments assessed at least annually? So are you doing an assessment with each person to find out, do they want to self-administer their medications, number one, and do they know enough about it to be able to decide if they want to or not? And, are we looking to see how much of that self-administration can they do on their own right now, and what supports do we need to put in place so the person, can do as much as they would like, or as much as possible? Are people provided the level of support necessary to ensure they take medications and complete treatments according to prescribed orders? Again, a really important part of this is it the level of support necessary? So it doesn't necessarily mean that we're going to do everything for someone, right? But we're only going to provide as much support as that person needs to do, what they need to do with their medications and treatments. And really, this can't be even done until we know if people have enough education about their medications to know why they're taking those treatments, right? Because if you just give me a pill, I'm not going to take it unless I know what it's for, right? So it's really important that all these pieces kind of go together. Probe 7, do people self-administer medications with support as necessary? So again, this is really making sure that people are only getting as much support as they need to administer medications. So if somebody maybe can't pop the pills out of the blister pack or open a pill bottle, are we looking at other ways to support that person to do that? Maybe an electronic minder is a better way to do that. I know a lot of organizations have started using things like Dose Health, which is an electronic pill minder that basically dispenses medications when it's time to take them and lets the person know, hey, it's time to take your meds. That's less restrictive than having a staff guarding the medications at all times, right? So really looking at ways to support people to be as independent as possible with medication administration, even if it's not in the traditional way we've always thought of. Do people know how to access medical emergency services? So do people know when to call 911 and what to call 911 for? Do they know what to do if something happens to them or another person they live with or a staff member that's supporting them? And do people have therapeutic and adaptive equipment as needed that fits them and is in good repair? So, eyeglasses, dentures, hearing aids, walkers, anything that kind of fits that therapeutic and adaptive equipment, making sure that people have what they need and they've been evaluated for other things they might need, and that it gets fixed when it breaks. Indicator B, people access quality healthcare. This is the example we went over very briefly. So indicator B has 5 probes. The first probe is, are the frequency and type of healthcare evaluations and screenings defined in policy? Do they meet applicable requirements, and are they consistent with the standard of care for prevention, early detection, and treatment? So there's a big clue in this probe. It says, are the evaluations and screenings defined in policy? So this is something that a lot of organizations miss, and it's really quite important for this overall indicator that there's a policy written about how do we make sure that people get the type of healthcare evaluations and screenings that they need? How do we make sure that they're meeting applicable requirements? What do we do when a provider doesn't meet those needs for a person? Often people who have disabilities don't necessarily get to have pap smears or other kinds of preventative testing that you and I get regularly, because providers may not have the education to know that that's something that people need. It's really important. So what do we do as an organization to make sure that people are getting those things and that it's meeting the standard of care for prevention, early detection, and treatment for all different kinds of things? So with that, are there standardized protocols for regularly required evaluations and screenings? So do we have just a standard way of making sure those things happen when they should happen? I often recommend that organizations look at the CDC and the American Heart Association and other resources like that to find out kind of what are the best practices right now, and then write that into their policy and update it as needed. Do people receive medication evaluations according to a protocol consistent with accepted medical practice? So we have to do medication evaluations annually, or making sure that those are following what our medical practice says they need to follow. And do we make sure that people are getting those evaluations of the medications they're currently taking to make sure that they're being effective, and to make sure that they're actually what's best for the person to receive for whatever thing they're taking that medication for. Probe 4, do people have current and relevant specialized healthcare assessments for seizure disorders, orthopedic and neuromuscular disorders, eating disorders, including dysphagia, gastroenterological disorders, and other nutrition concerns, psychiatric disorders, or any other health condition that typically requires evaluation by a licensed healthcare provider? So if somebody, needs to be on an altered diet, do we have documentation to back that up? And if people need second opinions or want second opinions, do they get those too? Especially with things like dysphagia, that's not necessarily going to be forever for some people, or some people might choose that that's not something that they, want to happen forever. Maybe our current assessment is outdated or something like that, and we want to look at getting something updated to make sure that it's still relevant to the person. But really being cognizant that we aren't just taking any doctor's word for it, and we're making sure we're getting those specialist opinions. Okay. And do people routinely receive comprehensive physical examinations? So it's exactly what it sounds like. Do they get annual physical evaluations? And Are they comprehensive? Do they cover everything they need to cover, all the body systems? Are we not just deferring things because people have disabilities or because it might be harder to get those screenings or evaluations done? Okay. Indicator C, data and documentation support evaluation of healthcare objectives and promote continuity of services. So this one's really about how are we making sure that we are supporting people to meet their healthcare objectives, and how are we making sure that people's healthcare services are, done in a way that makes sense for them and that they're meeting their needs. So are current and relevant healthcare evaluations and screenings documented in people's records? So when we get those healthcare evaluations, do we keep them? Do we have it documented in some way that makes sense to everyone? Do we make sure the person-centered plan has those results in there, including any recommendations? Often our doctors make lots of recommendations for us or other medical professionals, and do we make sure that that's documented in a way that it won't get lost and that we'll keep, working on that if that's something that's important to the person? Do people's person-centered plans include a description of healthcare support needed? So, back to the example of the gentleman who has diabetes, do we have in his plan written that, he takes metformin, or maybe he takes some other kind of medication to manage that, or maybe he takes insulin. Maybe he administers his own insulin, or maybe he needs staff to support him with that, or a nurse to support him with that. Is that written and clear in the plan what exactly needs to be done for, each healthcare need? Probe 4, do people's person-centered plans describe how healthcare services are reduced in intensity or discontinued as the person's needs change? Do plans indicate how both physical and behavioral health is monitored on an ongoing basis? So again, this is a twofold probe. Do we make sure that people's healthcare services are updated in their plans as they reduce in intensity or are no longer needed? So if I break my hip and I need to, use a Hoyer lift for a little while my hip's healing, am I getting the kind of support I need? But then once it's healed, does that get reduced in my plan? Does that get written in the plan that I no longer need the Hoyer? Do we make sure we go back and evaluate that? Do staff know what to do if someone's physical or behavioral health is changing? Do they know, exactly who to report that to? Does the organization have a clear understanding of how we're going to make sure that people are getting those kinds of things monitored? So if I'm taking psychotropic medications, do I see the neurologist or do I see a psychiatrist to look at those medications and make sure that they're still working for me, and that they're not having any ill effects on me or anything like that? Does documentation show that needed healthcare supports are consistently provided? Exactly what it sounds like, right? So if there's supports that I need, are we making sure we're documenting that we're giving them when needed? And does documentation show that healthcare supports are reviewed routinely by a person qualified to do so and at least annually by the team? So are the nursing assessments done to make sure that people are getting the kind of healthcare support they need, and that if people need more or less, we're changing that, right? And is there evidence to support that data is used to assess the effectiveness and progress towards achieving healthcare goals? Of course, this is exactly what it sounds like. If somebody has a goal to get off of all their medications, and part of getting there is that they need to lose weight, then are we using data to see how effective our plan is with the person to support them to have that weight loss? And are we looking at their progress and reevaluating the need for those healthcare supports, those medications, or whatever the case may be, as the person makes progress or as the person doesn't make progress? Because sometimes that could be directly evident that the healthcare goals either aren't going to work or that the medications aren't proper right now for what the person's goals are. Okay, indicator D, acute health needs are addressed in a timely manner. So this section is really about what do we do when people's needs are changing. Okay, so there are 9 different probes in here. A few of them are bolded because they're really, really imperative just for that foundational part of this indicator. So do support staff recognize and promptly report physical or behavioral changes, complaints of illness, accidents and injuries, or other signs and symptoms of illness? So if something is going on with a person, do we make sure that we are reporting that to people? Do staff know who to report it to? If someone's complaining of an illness, do they actually get an assessment by a nurse or by a doctor? Did they go to the clinic to have that checked out, or do we kind of wait on that? Do we have clear things that we're going to make sure happen if somebody falls or slips or gets hurt in some way? Do we have those kind of clear procedures in place? Does the organization have a process for ensuring acute health changes are assessed by a qualified healthcare practitioner in a timely manner? Depending on what happens, timely manner changes, right? So if I wake up and I have a slight fever, maybe I don't need to see my healthcare practitioner today. Maybe I need to see them sometime this week if it continues, and I'm just going to monitor it. But if I wake up and I have 104-degree fever, I probably need to see someone ASAP and get on something to lower that to protect my brain, right? So it really depends on how acute that health change is and, what level of support the person requires at that time. And do all staff understand that? Are supportive diagnostic studies, when indicated, obtained, and acted upon in a timely manner? So if I'm going to the hospital with that really high fever, are we doing different tests to figure out what's going on with me and to maybe diagnose what's happening in my life so we can get me some good support and some good health care to actually follow up on that? And do we advocate with providers to make sure that's actually happening? Are standing orders used only after a full nursing assessment that includes clear parameters for when to contact people's primary physicians? So a lot of times when people are in PRNs, whether or not that's a prescribed PRN or an over-the-counter medication, it needs to state how is this medication to be used. So Tylenol, for example, it may say, may be used for aches and pains and fevers over 100 degrees, for example. Please call the nurse after administration, or please call the nurse prior to administration and share the symptoms that are going on. And then if symptoms don't improve within 24 hours, call the nurse again, and the nurse will contact the physician, or maybe you call the physician directly or set up an appointment or whatever the case may be. Just making sure that there's really clear parameters for the staff to know what to do and how to use those medications and under what different circumstances they should be using medications and for how long they can. Do people's healthcare support staff recognize the need for a timely transfer to a higher level of care? So if something is changing with someone and they need more support than we can provide, are we making sure that we're getting that support quickly if it's necessary, right? Does the system for ongoing communication between people's healthcare support staff and outside healthcare staff promote continuity of care? So are we communicating with people's physicians and people's other healthcare providers, their nutritionists, their PT, OT, whatever the case may be? Are we making sure that we are contacting them and having conversations with them to make sure that nothing's getting missed and that we're making sure we're following up on all suggestions and that physician is kept in the loop if things are changing? Do people's records document hospital summaries that include discharge diagnosis, current health status, necessary follow-up instructions, and any restrictions or limitations? Again, this is so important to make sure that we have those right away when someone's being discharged from the hospital or if they're leaving the ER, to make sure that we know exactly what we need to do. If I have that really high fever and it turns out I have something that's contagious, maybe my discharge instructions are that I can't be around other people that may be likely to get the same thing that I have. Or maybe my limitations are that I can't go to work for a few days. Those are important things to have identified. Or maybe I need to follow up with the doctor again in 3 days or 5 days to check in and see how I'm doing. So do we record any healthcare changes to provide a clear picture of the course of the illness, injury, the treatment provided, and the person's current status from the time of identification through resolution? So if someone looks back in the record, can they see what happened with that fever, right? So-and-so woke up in the morning with 104-degree fever. We took them to the ER right away because that's not okay. The doctor did some tests. We found out that they had an infection. He put them on antibiotics for that bacterial infection and kept them for a day because the fever wasn't going down. When they were discharged, they had instructions that they weren't supposed to lift anything heavy and they weren't supposed to go to work for a couple days to let their body kind of recover, and that they needed to come back within a week. And is that all clearly documented? And we make sure that those things all happened, right? And then that's clearly documented in the person's record. And then are people's person-centered plans, including healthcare supports, modified in a timely manner based on acute healthcare changes? So if something has changed in my life, is that documented in my plan quickly? If I broke my hip and it's going to change the kind of healthcare supports I need, but it may change other things in my life as well, such as, where I live, at least temporarily, or, maybe I need to have a hip replacement that's going to involve some other things as well. do we make sure we get together and change that in the person's plan so all people supporting the person knows what to do? And do we make sure the person's involved in that conversation? If I break my hip and I need to move, that's something that I probably need to know ahead of so I can make good choices about where I may want to live while I'm recovering. Do I want to go to a rehab center or a nursing home, or do I want to just move into another place that's more accessible for me or that has more staff support? Really making sure that people are involved in that and that plans change so everyone is on the same page. All right, indicator E, people receive medications and treatments safely and effectively. So are medications and treatments prescribed in accordance with applicable laws, regulations, and related directly to outcomes identified in people's person-centered plans and preferences outlined in people's psychiatric advance directive? So exactly what it sounds like, we're making sure we're following all the laws, and we're making sure that we're only giving people medications for things that matter to them, right? I don't take vitamin C every day because I don't have a reason to take vitamin C every day. And frankly, taking an extra pill doesn't sound really pleasant to me, and so not worthwhile, right? So same kind of concept with people, making sure that the reason people are taking medications or doing treatments is because it's directly related to something that matters to them, right? Are people and direct support staff informed and educated about anticipated outcomes and potential side effects of medications and treatments? So notice this says people and direct support staff. So lots of organizations do a really great job of educating the direct support staff about the outcomes and side effects of medications and treatments, but sometimes where we fall down is making sure that people get that information too. So some of the best practices I've seen is that organizations that are administering medications, they talk to the person every time they administer medications, and they say, you know, this is your Lipitor, it's for your high cholesterol. These are the side effects. These are the things that we hope to happen because you're taking Lipitor. And do you have any other questions about your medication? Or and eventually that's most of the time leads to the person recognizing their medications and knowing what they're for and being able to say, hey, you know, you said that medication can make me dizzy and I've been feeling real dizzy for the last couple of days. Can we do something about that? Or, you know, those kinds of things. It really just makes for a safer environment for staff and for people, and helps people be more educated about their own medication and medical histories. Are medications and treatments reviewed at specified intervals and renewed based on an evaluation of people's responses and stated outcomes? So again, are we looking at those medications and treatments to make sure that they're still appropriate for the person and what the person wants and hopes to gain? Are medications and treatments administered in accordance with applicable laws and recorded at time of administration only by the persons authorized to do so? So are we, you know, documenting the medications that we're giving so that way we can ensure people are safe in taking those medications and aren't getting extra doses, and we know where those medications went and all of that good stuff. That's a law pretty much everywhere. So that should be happening, right? A few more probes here. So unless otherwise included in people's self-administration procedures, are medications, including non-prescription drugs, stored securely and in any other way required by law? So are we making sure that medications are locked? Are we making sure that narcotics are double locked? If someone self-administers their medications, do they have access to those medications in the way that makes the most sense for them? So maybe they keep them in their bedroom. Maybe they keep them in a lockbox that they have a key to. Maybe they keep them on their kitchen table because that's the best thing for them. Or maybe they use an electronic reminder. It just really depends on the person. And are we making sure that that's individualized for each person? And finally, are medication errors, adverse reactions, and drug side effects promptly reported and responded to in accordance with the organization's policy and procedure? And is this information documented in people's records? So if medications happen, which they do we make sure that we are following up on that immediately to figure out, you know, what happened? Is there any side effects because of this? Is there anything that we need to watch out for? Does the person need to go see, you know, an emergency provider right away? Making sure that all those things are happening, and then making sure that we keep that information in the person's records so we can identify patterns for that person, or so if something happens later down the line, we can see what happened, right? All right, finally, sorry, I'm going a little fast, guys. We're getting close to our hour already, and we still have a whole nother indicator. So indicator F, staff immediately recognize and respond to medical emergencies. Under this, there are 6 probes, I believe. Does the organization implement policies and procedures that ensure a rapid and effective response to people experiencing medical emergencies? So again, their big clue there, is there a policy and procedure that ensures rapid and effective response when there are medical emergencies? Do direct support staff receive competency-based training? So Is it something that we can prove that they really understand to recognize and respond to people experiencing medical emergencies? Do we have the equipment that we need to respond to a potential emergency available, as well as it being maintained, clean, and functional? So do we have all the things we need to do CPR in a person's house or in the vehicles we're using to transport people or at day programs? Do we have AEDs, especially if that's necessary for people who may be older, have heart conditions or those kinds of things? Really a good idea to have those if we can. Do we have other things that people may need to keep them safe in a medical emergency, especially ones that we can foresee that may be individualized for each person, right? Do we have emergency medication required by people available in the appropriate dose, quantity, and form? And do we make sure it's not expired? That's another important piece of that. So if people have seizure medications, do we make sure that they have that? If people have EpiPens, do we make sure that they have those and that they're not expired and that everyone knows how to use them? Are medical emergency responses implemented effectively and decisively? Do they consistently follow established policies and procedures? So if there's a medical emergency happening, does everyone know what to do, and can they just do it? Do they know to make that decision to call 911 or whatever they need to do at that time? Do they just do it? Do all staff in direct contact with people receiving services have a minimum of first aid, CPR, and general medication training, including how to recognize harmful side effects? Again, the area here that's really, really important, because it often gets missed, is that general medication training for all staff. So regardless of how long you've worked with people, even if it's your first day on the job, do you know how to recognize harmful side effects if you're working directly with people of the people's medications, even if you're not medication trained yet, because you are that person that knows what the person is experiencing and can identify that the quickest. So it's really important that all staff have that general medication training that are doing any kind of direct support. All right, so that's all for the indicators and probes. If you guys had any questions, please make sure you throw those in that comment box. We're gonna come up on the questions pretty soon here. So we've had quite a few webinars in the past that are related to health. You can find any webinars that we've done in the past on our website in the resource library under webinars. A couple that I found were Advancing Recovery in Behavioral Health, Supported Decision-Making and Emerging Model, and Disability Inclusion and Physical Activity. Those all touch on different pieces of kind of best possible health for people. Another great resource is to look at those decision-making in personal outcome measures as well. They talk a lot about health and what that means to self-manage healthcare and understand medication and medical histories. Of course, there's also written literature on our website too that pertains to health that you can find also under the resource library. So when we're doing an accreditation, after we've gathered all of our evidence, we look at validating that evidence and making decisions. So each probe is validated present or not present based on evidence obtained during the review. Each indicator is validated at the system. So remember, that's your policies, procedures, your written manual on how to do this, and the practice level. So that's what you're doing. And indicators are validated based on a preponderance of evidence related to an indicator. And it's not based on the number of probes found to be present or not present. So the reason that is because sometimes some probes are weighted a little bit heavier because they have a bigger impact on the overall, status of that indicator being present for most people. During an accreditation, if an indicator is found to be not present in systems or practice, an action plan is required. And so that action plan may pertain to just system, just practice, or both system and practice for an indicator, depending on what we validate. And the title of the indicator is not always a complete description of all the elements contained within an indicator. So just simply reading that indicator won't tell you why it's not in place. You really need to look deeper into the basic assurances and read those individual probes to make sure all the pieces that were not in place are addressed. So an example for best possible health is indicator 5A. People have supports to manage their own health care. Probes 2, 3, and 4 out of the 9 different probes really address people's understanding of their health and support to manage their own health care. And this area is considered fundamental and would have a bigger impact on validation than the other 5 probes or 6 probes. So do people make and keep their own healthcare appointments is what 2 is. Are people provided all the understandable information about their health? Do they understand that? Are they making their own choices? And have they been given the option to make advanced directives for their healthcare? And do people understand their medical and medication histories? Those 3 probes have an outsized impact on validation, and we'll see later that they also have an outsized impact on overall on all of the basic assurances in indicators in factor 5. There are some red flags in healthcare, and I know that this hasn't always been talked about in the previous webinars, but I thought it was important in this one because they're kind of just really basic things. So if red flags are noted by CQL, it might bear further investigation and inquiry by us. We'll determine whether a situation is isolated, so it just happened once, or it was just kind of one of those things that we don't know how it happened, right? Or if it's a systemic pattern, right? If there's something that we're failing to do that's causing this to happen over and over again, or if it could happen over and over again. Some red flags may jeopardize accreditation or require additional monitoring to maintain accreditation. So for best possible health, that's if people don't have adequate diets or hydration, if there's a pattern of disregard for infection control measures, or if people are not being provided or supported to access healthcare. Inadequate monitoring, oversight, or support for people to self-monitor chronic health conditions such as diabetes, hypoglycemia, blood pressure, or certain medications that require monitoring to determine titration or adverse reactions. So, you know, when those things are happening where people have those really sensitive kinds of diagnoses, we have to make sure that we are providing really good supports to people to the level that they need to make sure that they're going to remain safe and in a lot of these cases alive. Necessary or appropriate medical intervention or follow-up care was not provided in a reasonable or timely fashion. So if someone goes to the doctor and they need follow-up with a specialist or something else and we don't do anything to make that happen, or if there was an injury and we don't check in on it, or someone's ill and we don't do those things, and that would probably be a red flag. Any medication error that necessitated aggressive emergency intervention or a pattern of medication error that results in an adverse result. That's pretty self-explanatory, right? And then staff or people supported require permission prior to contacting emergency services. So it's always really important that people supported and their staff can contact those emergency personnel when they need them without having to ask anyone else for permission, right? If your gut tells you that you need 911 services, then you should be able to call those services and not get in trouble for that or fear for your job or anything like that. So when you're looking at factor 10, which is that overall integrated quality management system, the things that you might pull out for factor 5 to measure are medication errors. That's not the number of medication errors overall, but the percentage of medication errors from the total number of medications that are given. So if an organization gives 120 medications in a day, because they're a pretty small organization or people don't have a lot of medications, but they have 12 medication errors that day, that's a good percentage, right? But if they have 12 medication errors and they give 12,000 medications in a day, that's a much smaller percentage. So really looking at that percent error rather than the number of errors. Hospitalizations. So this is all kinds of different things with hospitalizations you might want to look at. So maybe why people are being hospitalized, the percent of people that are being hospitalized, and comparing that to, you know, year to year or season to season or whatever the case might be for that is appropriate for your organization. Maybe looking at the number of days people are hospitalized might be an interesting thing to look at too, depending on your organization again. ER visits. So how often are we visiting the ER? What are we visiting the ER for? What percentage of people visit the ER? Is there any certain people that visit the ER more than others, or maybe certain locations that visit more than others, or certain programs that have to go to the ER more, and figuring out why that is, and looking at that kind of over time. Use of sick days. So this will be for people supported. How often are people supported using their sick days, and what are they using them for? Are they calling in sick because they, you know, maybe don't have good mental health and they need some more counseling supports? Are we making sure that, you know, we're really looking at the reasons around those, if at all possible, and just figure out the percentage of sick days. Use of PRN medications. So this might be those over-the-counters, but it's more likely going to be beneficial to really look at those psychotropic medications, if there are any PRN psychotropics, or other kind of prescribed medications that are PRN, and, you know, maybe looking at the percentage of people that have those, or the amount of times those are prescribed for or given for a certain person, those kinds of things. There's a lot of other things that are measurable in factor 5 that you can look at as well. So Carly pulled some beautiful data for us based on 177 organizations from 2015 to 2017. So this is the average number of indicators present in system and practice for factor 5 for the 177 organizations. So 11.2 of the 12 possible factor 5 indicators, so that's both the system and practice for those 6, were present for all organizations. So 93% of the time this was in place. When we break it down by system and practice, on average, agencies had 5.6 out of 6 possible factor 5 indicator practices in place, which is 93.5%, and an average of 5.5 of the systems in place. This is a really interesting slide to look at. 5A system and 5A practice are the lowest ones here, and that's exactly what I would have expected before I even saw this data, that self-management or people being able to manage their own healthcare is definitely the area that's the hardest for organizations to get in place. Number one, because they don't have systems in place to make it happen, and number two, it's just a harder thing to do to really support people to understand all of those different pieces. Another area that's not really surprising probably is that 5B system. So a lot of organizations don't have a policy in place, not a lot, 13% don't have a policy in place that lays out what those different preventative healthcare things are, those evaluation screenings and stuff. So those are some interesting things to see. But overall, looking at 5F, you know, that's really, really strong for a lot of organizations, and so is 5E with medications. So that's cool to see. This is a really interesting data set. It looks at the differences in the organization's self-assessment and CQL reviewers for the factor 5 indicators. The numbers show that the organizations significantly overestimate the presence of almost every indicator, but especially 5A system and practice and 5B system, which, you know, isn't shocking. Again, if you remember on the last slide, those are the areas that are a little bit harder for organizations to get in place, but coincidentally, our organizations overestimate how much is in place here. So yeah, organizations thought that those were in place up to 20% more often than CQL assessed them to be. And this is the impact of factor 5 on the total basic assurances. So according to our statistical analysis, the more factor 5 indicators an organization has present, the better they do on the total basic assurances. For example, an organization that has none of the factor 5 indicators present is expected to have 30% of the total 92 indicators present, systems and practices. Whereas an organization that has all 10 of factor 5 indicators present is expected to have a 91% of the total basic assurances present. When organizations attend to best possible health in both their systems and practices, they're not only significantly more likely to have all the other factors present, they're also more likely to have enhanced quality services. All right. And then just like we do with the POMs, we like to look at the outcome correlations. So the numbers indicate the relationship between this probe and the total factor 5 score. So the important thing to note here is that they're listed in order of importance. So the most important, if you will, for saying that the factor 5 is going to be in place all the way is that 5A3 is in place. Are people provided all of that information they need about their health, the medications and treatments, which makes a lot of sense because a lot of this whole factor builds on what people know about their health and what choices they're making. The next one, again, is from 5A. Do people understand their medical and medication histories? 5B3, do people receive medical evaluations according to protocol consistent with accepted medical practice? And just down the line, it's a really interesting slide to look at. I suggest that you guys all go back and look at this slide when we have the webinar come out. I also think it's interesting that most of them are from 5A, which coincidentally is the hardest system in practice to have in place for organizations. Well, if you guys have any questions at a future time, please feel free to reach out to me. My email is on the screen right there, or you can find my email on the website. Thank you guys for all attending today.
Thank you, everyone. Thank you, Kendra.